So I spoke yesterday about Venetoclax resistance in acute myeloid leukemia. I think it's a very challenging topic and very timely topic because of very broad use of Venetoclax in acute myeloid leukemia. Of course, it's approved for older patients unfit for chemotherapy, but it's being used off-label for younger patients, for patients who are relapsed refractory. So it's a very important topic. So we have done a lot of research trying to understand the mechanism of resistance. So I described sort of on-target mechanism of resistance, which have been described by others. For example, there have been reports in CLL that there are BCL2 mutations, but we don't find them in acute myeloid leukemia. So it's really like disease specific. But there was a report last year at ASH that there are VAX mutations in AML, and VAX is really important for Venetoclax to work. So right now we're not monitoring for this, but we probably should in the future. And we're not sure how to address those. And then I moved into other what we identified the most common mechanism of resistance. So one is mutations in what we call signaling pathways, such as most commonly FLT3-ITD. I showed the data from subset analysis from the early A study and the phase 1b study of hypomethylating agent Venetoclax, where patients who had FLT3-ITD, they really did not benefit from the aza-ven compared to azacitidine alone. So then I pivoted into mechanisms why that is the case, and based on our lab findings, we identified that the FLT3-ITD mutated cells, they quickly escape Venetoclax by upregulating MCL1 protein, which is another member of BCL2 family member, BCL2 family proteins. So we also showed that by inhibiting the FLT3 kinase by specific inhibitors, you can actually sensitize to Venetoclax because it will downregulate MCL1. So we did like preclinical work, and that was followed, or in parallel, the clinical trials have happened that combined Venetoclax and FLT3 inhibitors such as gilteritinib, and that showed high activity in the relapse refractory setting. So now it's moving into frontline in the what we call triplet therapy with azacitidine, gilteritinib, and Venetoclax in newly diagnosed patients with FLT3-ITD. So we're very excited about that. So then I also described other signaling mutations such as RAS mutations that we commonly see escaping Venetoclax, and they kind of work through the same mechanism downstream through upregulation of MCL1. And we published recently that if you use BCL2 plus MCL1 inhibitors, you can overcome that mechanism, but unfortunately clinically we don't have right now any MCL1 inhibitor that is FDA approved. So it's we're not quite sure what to do other than MCL1 inhibition that hopefully will come to fruition. And then finally, the last piece of my presentation was on the most difficult mechanism of resistance, which is p53 mutations in acute myeloid leukemia. So there was preclinical work from other groups that showed that it's how that really impairs the efficacy of Venetoclax, and we identified that as the most common mechanism of resistance based on analysis of patients treated with Venetoclax. So right now, what the approach we took is to try using immune therapy in combination with Venetoclax. So we studied the combination of magrolimab, which is don't eat me signal for CD47 inhibitor, in combination with Venetoclax, and we showed that the combination works better even in the setting of Venetoclax resistance or even in the setting of p53 mutation in AML. So the studies are also ongoing, including our institutional combination, and that will be followed by randomized studies in the near future. So this was a brief summary of my talk. So I think I'm sure there are many more things to discover, but this was